So the first question with treating with an untreated mantle cell patient is really thinking about what their ultimate goal is in terms of getting a transplant or not. And that's kind of an evolving space as well. So maybe thinking more along the lines of, are they a candidate for aggressive induction regimens, or would they be better suited for less aggressive regimen? In terms of selection of BTK inhibitor in the frontline and maintenance setting, the data that we use to inform that selection comes from the Triangle trial, which incorporated ibrutinib into both regimen with alternating R-CHOP and DHAP, and then into maintenance after transplant or without transplant as a maintenance regimen. Because there has been a lot of data that's come out showing that newer covalent BTK inhibitors such as acalabrutinib and zanubrutinib seem to be as effective as ibrutinib in many different spaces, and certainly have less toxicity and are able to be better tolerated by patients. For many lymphoma subtypes, including mantle cell lymphoma, we are now selecting these newer covalent BTK inhibitors over ibrutinib. So even though ibrutinib was the drug that was studied, was incorporated into the regimens in the Triangle study, the NCCN guidelines actually have a category 2 recommend to select a newer generation BT's place for the reasons that I just mentioned. So we kind of extrapolate and use either acalabrutinib or zanubrutinib in that place.